Good evening, everyone, and welcome. My name is Ken Lippy. I'm Deputy Superintendent here at the Marin County Office of Education, and it's my pleasure to welcome you to a very important hour. We're so glad you joined us. A few points before we start about this webinar. First, it will be recorded, so it's going to be available for future viewing. You'll be able to find it on the Rethinking Schools website or at marinschools.org. We also will have this presentation in live translation in Spanish. We're so thankful to Marta Biton, who is our interpreter this evening. And now I'd like to turn it over to my colleague, Michelle Drake, who will tell our audience how to access the Spanish translation.
Thank you, Ken. Hola, bienvenidos a todos. Este webinar se transmite simultáneamente en español. Haga clic en el botón de interpretación del idioma que aparece en su pantalla si desea escuchar esto en español. Muchas gracias a Marta Biton, que es nuestra intérprete esta noche. Gracias. Thank you.
I want to start tonight by thanking our community, our schools, and of course, our health leadership in this community for the support and guidance that's been so essential to keeping our schools open and safe over these many, many months. We've been coining it, thanks to Dr. Willis, as radical collaboration. And that's certainly what it's been. And look what it's resulted in. 95% of our school staff are currently vaccinated. 85% of all of our eligible students are currently vaccinated. And the vaccination rate for our entire community is now well over 80%. It's no wonder that this community has banded together so well with the guidance and leadership and collaboration we're seeing from so many partners. We have so much to be proud of, but we know that there's much more work to do. And that next step in that work is the vaccination rollout opportunity for our 5 to 11-year-olds in this community. Over the last several weeks, we've received literally hundreds of questions about the pediatric vaccinations and their rollout. We've taken those questions, and tonight our panel will be addressing as many of those as possible in the next hour. We think we're going to touch on a lot of very important information, and that's great because we know this is an important decision for families. And the best thing we can do is provide you with the information from the experts that guides you in that decision. I also want to remind you that because we took questions in advance, we will not be taking questions live this evening or in the question and answer format of this webinar. We will, however, be addressing many questions that came into us in advance. So, as you're aware, the Food and Drug Administration has authorized emergency use for the COVID-19 vaccination for children ages 5 to 11. And the Center for Disease Control has recommended the vaccinations for those children. California's governor has mandated that when there is full approval of the COVID-19 vaccinations, similar to other vaccinations, that vaccination will also be required for all eligible students. There's a real chance that a vaccination will be required for students for the 2022-2023 school year. Tonight, we're going to hear from pediatric experts who will discuss the COVID-19 vaccinations and the approval process and the anticipated upcoming opportunities, including a kickoff this weekend with a vaccination superpod at Miller Creek Middle School. More details about that will be put into the chat and provided later this evening. But we're very happy to see that kickoff. Now let's get started and meet our panel. Dr. Nelson Branco is a pediatrician with Tamalpais Pediatrics and is on staff with Marin Health. Dr. Branco, originally from Massachusetts and attended Boston University for both his undergraduate degree in psychology as well as medical school. In 1995, he moved to California for his pediatric residency at Children's Hospital in Oakland. Then he and his wife Nell moved to Shiprock, New Mexico to work with Indian Health Services in the Navajo Nation. He spent 3 years there practicing pediatrics in New Mexico. In 2005, Dr. Branco joined Tamalpais Pediatrics. He's active with the local chapter of the American Academy of Pediatrics and has been a member of that academy's committee on Native American child health. Most importantly, and so pertinent to tonight's conversation, he is the father to 3 children. We're also joined by Dr. Lisa Santora. Dr. Santora has served as the Deputy Public Health Officer for Marin County since 2015. She completed her undergraduate study at Fairfield University and received her medical doctorate from Rutgers, New Jersey Medical School, and has a master's of public health from the University of Buffalo. Dr. Santora has regularly been meeting with our school and community leaders. In fact, I think this is her 5th meeting today with community, and has been essential to the school process of implementing COVID-19 testing and vaccinations for those eligible in our community. And Lisa is a mother of 2 elementary age children. Dr. Matt Willis. Dr. Willis has served as the public health officer for Marin County since 2013. Dr. Willis completed his undergraduate study at Brown University. He has a master's of public health and internal medicine residency from Harvard, receiving his medical doctorate from Temple University. As public health director, Dr. Willis co-founded the RX Safe Marin Coalition to address opioid epidemics locally. He served in the U.S. Public Health Service as Director of Primary Care on the Navajo Reservation and at the Center for Disease Control in Atlanta, where he conducted research and outbreak investigations. Dr. Willis is the father of 3 children. So now we turn to our panel and a number of very important questions. And to kick us off, we have Dr. Willis to supply some info for us. Doctor.
Thank you, Ken. Good evening, everyone. It's exciting to be here with you tonight. I'm not sure we could have timed this any better. When we were trying to figure out which night to hold this forum, we thought November 3rd made sense. Little did we know that that would be the hours after the authorization actually came through from the governor today. So this is a really good chance to kick us off and share our excitement for what this represents for the health of our community, and for my personal excitement that my 11-year-old is now going to be able to get vaccinated as early as tomorrow. Just want to offer, some of these. This is our 3rd forum around pediatric vaccines with the community, these town halls. Tonight's going to be more open, more question and answer, less data. We will have a summary of the data from the trials that were considered on October 26th by the FDA, and then November 3rd by the CDC, and then again last night by the Western States Scientific Review Group, and then today by California Department of Public Health. All those steps that led up to today's authorization. Dr. Santora will summarize the key elements of those studies that they are considering to make that determination, and then we'll have plenty of time for questions and answers. Many of those questions, more than 100 questions that were submitted over, and we've picked the ones that I think are most relevant to our community. Just to step back, we are now in Marin County in the CDC's orange tier of substantial transmission rates. We are in that we are like every other county across the entire western part of the United States, Washington on down to Southern California. We had been the last holdout in the yellow tier and had been the first to enter the yellow tier. We have the lowest case rates in the state of California. We've crept up over that margin into orange. The good news is that for the first time yesterday, we had no people in the hospital in Marin County with COVID-19. That hasn't happened in about 5 months. So we're seeing significant progress. And that association of low case rates and no one in the hospital is really directly attributable to the other element that stands out about Marin County, which is high vaccination rates. We have the highest vaccination rates in the state of California, and that is the reason why we have the lowest case rates. That is the reason why we have no one in the hospital in Marin County. And yet that benefit of the vaccine, the protection, the safety, effectiveness of that vaccine has not been available to 20,000 of our Marin County residents who are age 5 to 11. Starting today, that changes. And we're going to be able to offer the vaccine to those that haven't had the benefit of that thus far. And that's going to be really an important layer for us to add protection as we move from a pandemic experience into an endemic experience where COVID-19 will be part of our lives moving forward. We really want to make sure that our children are well protected for what will likely be an inevitable exposure to this virus that's going to be with us for months and years. And with that, I'll hand it over to Lisa to begin the summary of the trials, and then we'll start with questions and answers. Thank you.
Thank you. So you're just going to run through a bunch of slides. There's a lot of information on the slides, and we won't be able to hit every point, but they will be available and posted to the website. And I want to thank Dr. Ted Ruel, who prepared these slides. He is a local pediatric infectious disease specialist who works for UCSF, and we're really fortunate to have his expertise in the community. So you can jump right ahead. The first question is really about the dose. We saw when adolescents received the vaccination that they had a very strong immune response. And so when we were looking at vaccinating children, we were of a younger age and smaller in size and weight, we were looking at new doses. So the first phase was looking at 3 different doses, 10, 20, and 30 micrograms. If you have received the vaccine, you received the 30 microgram dose. And I wanted to see at those different doses, what was the immunogenicity? So how much did they promote an immune response in the children that received it? And also the reactogenicity, which is the safety or side effects experienced by kids who received those 3 different doses. Jump ahead to the next slide. And so this is a very busy slide, but once you get oriented, you'll understand it. There's 2 rows. The row 1 is the dose 1. And then the second row is the dose 2. And then there's columns that show the common side effects from receiving this vaccine. And then in each column, there's 3 different intervals. So, or increments where it's 10 micrograms, 20 micrograms, and 30 micrograms. And if you look at the first column, you'll see fever. It's a common side effect of vaccinations. And you'll see after the first dose, there weren't high reports of fever in children that received any of those doses. Then you jump down to that second row and you'll see in the second dose, the children who received 30 micrograms, 100% of them had fever. So again, this shows that it's a very reactogenic at that dose. And then jump across to look at muscle pain, another common report of or side effect from vaccination. And you'll see in the first dose, it's that group that received the 30 micrograms that had 100% again report of muscle pain. And then when they were in the 10 microgram group, they only had 12.5%, and that reduced to 0% after they received the second dose. So again, this really informed the selection of the dose to study moving forward. Anything you want to comment on this one?
No, I think that you summarized it well. I think one thing that people often ask is about dose and age and why we even started out with a 30 microgram dose for these small children. And I get lots of questions in the office about, I have a really tall, big 11-year-old and a tiny little 12-year-old, and why are they getting different doses? And so I'll jump ahead and answer a question that came across several times, which is that the immune system is not weight-based. Mm-hmm. So I tell people all the time, when you call me and ask how much Tylenol should I give, I have to know how much your child weighs because that is based on weight. It's not that way for vaccines. There really are very few vaccines where we give a different dose to adults and kids. And so this was a finding that came from recognizing how reactogenic this vaccine was in younger kids, in the teenagers. And so that's why the phase 1 study looked at those 3 different doses. So sorry, just to jump ahead and answer a question.
That's
using
great.
That data.
All right, jump ahead to the next slide. And so now we take a bigger group. So we've selected the right dose as the 10 microgram dose is considered the right dose. And then they enrolled more than 4,500 children in the study. More than 3,000 received the vaccine itself, and more than 1,500 kids received the placebo. And again, you're taking a smaller group and now applying it to a larger group with this 10 microgram dose. So you can jump ahead. And this is a really important slide. And I'm not expecting anyone to know what the numbers mean or what GMT means, but basically we're looking at the amount of antibodies produced by different age groups with different doses. And so we're looking at the 5 to 11-year-olds who received the 10 microgram dose, and then compared that to 16 to 25-year-olds who received the 30 microgram dose. And you can see actually the 5 to 11-year-olds who received the smaller dose edge out that 16 to 25-year-olds just a little bit in the amount of antibodies that they produce. And again, this is very consistent with the science that we've seen, that kids have different immune systems. They have stronger immune systems than those over 40 who are sitting at this table. And so that's why they have such a strong immune response who are, see, I was being kind. They have such a positive immune response to receiving the lower dose of the vaccine.
And just to add that that's sort of the inverse of what we're experiencing in our older population. Right now, one of our big emphasis is trying to get our residents age 65 and older in to get the booster because they don't have that same youthful immune system that the benefit of our children.
And the other, theory behind, again, the 11-year-old to the 12-year-old is there may be something that happens with puberty, some hormonal effect on the immune system. So it's not size, it's development. And, in pediatrics, we have to consider both. And so that may be one aspect of what's happening. It certainly is one aspect of what's happening with one of the side effects that we're concerned about that we'll get into in a minute.
Although I think my 11-year-old is early into his puberty brain, so we'll see. So we
He'll
can
still make plenty of antibody.
So we'll jump ahead. And this is the last thing that we're looking at. So we're looking at both at the vaccines promoting an immune response, the safety profile of the vaccine, and then is the vaccine effective in reducing infection and transmission? And so just to remember that for most of the children who were exposed to COVID during the study period, they were exposed to the Delta variant. So this is where there is a known mismatch between the vaccine that they received, which was developed to the Alpha variant and to the Delta variant. And you now can still see that even though the vaccine's not this perfect match, that we have a 90% efficacy. So if you look at the placebo group, that's around 1,500 kids who received the placebo, so just a saline injection. 17 of those kids had a COVID-19 infection during the first 120 days after their first dose, and compare that to the vaccinated group, which again is more than 3,000 kids who received this. There are only 3 cases of COVID-19 in this study group. Jump ahead. And then this is a very busy slide, but again, this is where we're looking at all of the different side effects that can be caused by a vaccine. And we're comparing the side effects between the different doses, the first dose and the second dose, and also looking at the side effects you see between those who received the placebo versus those who received the actual vaccine itself. And it's not uncommon to see side effects from a placebo because there's something in the saline injection called excipients. And so even a child who receives just the saline injection with some additional ingredients to stabilize the injection can have some side effects, because just like any medication or vaccine, there can be side effects. So it's not surprising to see side effects in the placebo. But what's really reassuring to us as clinicians is that the side effects were overall very mild side effects. We had no cases of anaphylaxis. That's the severe reaction. You can actually see the hypersensitivity and the angioedema, which is a swelling in oftentimes the site where the arm where you receive the injection, was comparable in both the placebo and the vaccine group, and even edged out in the placebo group for angioedema. And then more importantly, with this group, we did not see cases of myocarditis or pericarditis, and there are no deaths reported for this group. All events are reported during the study. So there's events, you'll see bug bites and knee infections that, again, there's no causality between these incidents and the vaccine itself, but they're reported and studied. And if you go to the FDA site, you'll see all the different reports of side effects from bug bites to hypersensitivity.
And a swallowed penny.
I did not know about this.
There's a swallowed penny in the study.
Placebo or vaccine group?
In the vaccine group.
Oh.
Yeah. So,
I don't know
why they left it off the slide. That's the most interesting, serious side effect.
Yeah. So I think, and again, their side effects are real. And we know that parents are making hard choices and really looking at the side effects and weighing the risks and benefits of natural immunity and the outcomes that they would experience with natural immunity, as well as the side effects that they would experience with the vaccine themselves. And every mom who brings their kids in for a vaccine, that's what you're worried about, is having side effects. And overall, the reason why this was passed by all of the different advisory groups is the side effects, which overall are very mild. And it's not to discount any child or family who experiences a severe side effect, because they are possible. That's the reality with the families that we know who have experienced myocarditis. They are serious side effects to that family. But on the whole, the side effects are mild and much less significant than the adverse outcomes that can result from natural infection itself.
If it's okay, I think I'll comment here, and you can go to the next slide. It's just as relevant on the next slide. But there are a lot of questions in the last webinar that Dr. Santora and I did with Dr. Rule, and a lot of questions we're getting from parents about, serious side effects. Was the study, large enough to find serious side effects, and then long-term side effects? And I think it's worth talking about long-term side effects versus uncommon side effects, because we tend to lump everything together. There were no cases of myocarditis seen in this study. We know that myocarditis is very rare. We know that myocarditis happens more often in teens, even viral induced myocarditis, so not with vaccine, but through other illnesses or due to other illnesses, due to viruses. That happens more often in males. It happens more often in teens, just like we saw with the vaccine in teenage boys. That wasn't picked up until lots and lots of doses of vaccine had been given. And so again, as parents have questions about this vaccine, I think we need to be honest that as we give lots of doses, we may see these side effects. We expect them to be very rare. We expect them to be just as rare and less so than what we're seeing in older kids. But that is something that we will find out as we give lots of doses. The other question I get a lot is about long-term side effects. And we know that with all the vaccines that we give, and as I said before, I've been doing pediatrics for 25 years. I have maybe given 1 million vaccines. I don't know, close, many hundreds of thousands. Almost all of the side effects that we see are within 8 weeks, within 2 months. We have tracked the kids who got this vaccine from 5 to 11 for longer than 2 months, and we have not seen a significant number of increased side effects. And so when we talk about long-term side effects, there's no science that makes us think that there will be problems a year or 2 years or 5 years down the road from this vaccine. There's nothing in the vaccine that makes us think that. We do know that, as Dr. Willis said, we are living in a world with COVID, and we are now faced with the option of our children being exposed to the COVID protein from a vaccine or to COVID, the virus. That's going to happen, and we have to live with that. And so which of those two situations is less likely to cause a long-term issue? The vaccine every time. It's sort of that's what the science tells us.
The infection will cause a long-term issue.
The vaccine is less likely to cause a long-term, I may have left out a word, my apologies. But the vaccine is far less likely to cause a long-term issue than the infection is. And so I'll always choose the vaccine, but we have to be, I think it's worth separating out, long-term versus uncommon, because those are a lot of the questions we get.
And I think that's one of the things that I've not seen in my career until now, just the strength and robustness of our reporting system with the technologies that we have today, with electronic health records that providers have, and with increased efforts to strengthen the vaccine adverse events reporting system. This is the most scrutinized vaccine that has ever been deployed in our global history. And in the United States, it's again a very robust system of surveillance for those adverse effects. And even again, we're now in the post-marketing phase, and we'll be in that post-marketing phase for the 5 to 11-year-old group, where they'll be looking for what they call signals, where in the reporting events, are they finding any clusters of any uncommon events in case they do need to reconsider the vaccine, which we also have seen in our career too with vaccines, with the rotavirus vaccine specifically. It's again, a vaccine that I think about a lot as a parent and as a provider, because rotavirus is one of the vaccine preventable diseases that I saw in my residency. There was a vaccine that was released, but that was saved hundreds, if not thousands of lives. There was surveillance of the vaccine that found that there was an adverse effect. The vaccine was pulled back and then manufactured and re-released. And it's now, again, continues to be a critically important vaccine, and that continues to save thousands of lives and prevent hospitalizations and deaths. So that's an important part of our system, is this surveillance and safety. And again, this is just the last slide, just really looking again about the adverse outcomes that are related to COVID-19 infection. They looked at deaths over a year, and where there were 84 deaths from the flu over the last year, there were 66 deaths in children and adolescents from COVID-19 over the past year. And it's ranks right, I think right now around number 11 for the cause of death for that 5 to 11 age group. And then when we look at hospitalizations among adolescents who are vaccinated, we see, again, consistent with what the data that we see in our county, it's that it's unvaccinated adolescents who are getting hospitalized, and only 3% of vaccinated adolescents have required hospitalization due to COVID-19 infection. And then more importantly, none of the vaccinated adolescents that have been studied have required admission for intensive care. So it's the protections that we're seeing for vaccination for adults is similar to what we see for both the pediatric and what we anticipate for the pediatric population, as well as for that adolescent population. Anything to comment here before we jump? I think that's it. I think we're in question and answer time. All right.
Yeah.
Thank you.
Okay, well, great. Well, that was really compelling information, especially since so many of our questions that we received dealt with the process, the research, the studies that have been done, what kind of data has been collected. And just as a reminder to everyone that those slides and all that information will be included in the recorded presentation that folks will have access to. So maybe now we do get to some of these questions. And Dr. Branco, we're going to start with you.
Mhm.
The first question is, there have been reports of menstrual changes in young women and myocarditis in young men who received the vaccine. Can you please speak about those risks, and what other risks do children face with this vaccine?
Sure. So I think, we've talked about some of the common side effects in terms of the risks that we anticipate. We expect the side effects that we've seen in the studies that we've seen in adults: fever, sore muscles, fatigue, headache, all of which I experienced with all of my doses. Some rashes, some local allergic reactions, those are common. We have not seen any more significant risks. Again, we've talked earlier, the dose was lowered to 10 micrograms because there was an acknowledgement that younger kids are making more antibodies and having a more vigorous immune response. The antibody level seems to be related to the risk of myocarditis in the teenage boys. And so when we look at the data of myocarditis after COVID vaccine, it was very clear that it was males, and I think 16 to 19 was the age range or the age band or somewhere thereabouts, that were at highest risk. And they had a risk of 66 cases per million doses, which is higher than the rate that we would see before. There was a question that came in that said, what is this myocarditis thing? We had never heard of that before. And I've certainly heard of it. I've taken care of kids with myocarditis. Most of the kids I've taken care of with myocarditis were in the ICU when I was a resident, and a few afterwards. It's usually a pretty serious illness. It affects the way the heart can pump, causes lots of inflammation and lots of what we call morbidity. It's a very impactful disease. What we've seen with COVID is called myocarditis, but there are a lot of us that wish it had a different name because it's just not the same disease. It's chest pain. There are changes on the EKG. There are some labs. There typically is not as huge an impact on the ability of the heart to pump. And in the studies looking at these kids who have had this and following them up, by day 35, most of them had returned to 100%. And so this is a condition that's being followed. There are kids who are being studied and having ongoing testing, but the myocarditis being seen with the COVID vaccine is not the same as the myocarditis that's seen from hand, foot, and mouth disease. That virus, Coxsackie, is a very common cause of myocarditis, for example. In terms of the concerns around fertility and menstrual irregularity, I spend a lot of time talking to girls and young women about their menstrual cycles, and I know that when they're sick, when they're stressed, when things happen, their menstrual cycles are thrown off. I think that the immune response to the COVID vaccine was responsible for a lot of the menstrual irregularities that have been reported and confirmed. It definitely happened. In the studies early on of the COVID vaccine for licensing, even though women in those studies were excluded if they intended to get pregnant, some of them did get pregnant. Since licensing and since all of the many doses that have been given, there are thousands of women who have gotten pregnant after vaccination. And there's really no sign that this vaccine affects fertility at all. There's no science or theory as to why it would. mRNA and DNA, I think folks confuse the two. They think that somehow the mRNA can affect your DNA, but there are not the enzymes in the vaccine that would allow the mRNA to get anywhere close to your DNA. And so it cannot change your DNA. It does not enter the nucleus. And it doesn't affect fertility in boys or girls.
There's an interesting parallel, I think, between the conversation about myocarditis and what we were talking about 4 or 5 months ago with blood clots in adults, which is, there is and it makes sense that there's an association between some of the side effects or adverse events related to the vaccine and what you actually experience with COVID-19 infection itself. And there were many who thought that the withdrawal of the J&J vaccine was actually premature and unnecessary because it might have led fewer people to be vaccinated. And actually the risk of blood clots themselves in COVID-19 infection was so much higher than it was for the vaccine that there's still debate now whether it was appropriate to withdraw, even though we did recognize that there was a rare side effect or adverse reaction related to that vaccine around blood clots. If enough people actually didn't get vaccinated because of that withdrawal of that vaccine for a period of time, we actually might have had more blood clots overall because more people were getting infected and the risk of blood clots was much higher. Similar for myocarditis. Myocarditis is not uncommon for people who are actually infected with COVID-19 infection. It is very rare for people who are vaccinated.
Yeah. That conversation actually reminds me a lot of the polio vaccine switch. Early in my career, we used oral polio vaccine. I think those of us here at the table all got the oral polio vaccine. Once that vaccine in 1 in 6 million doses actually caused polio. And, 25 years ago, we reached a point in the US where the rate of polio that occurred naturally was less than 1 in 6 million. And so we switched from using the oral polio to the injectable polio because that one didn't have that side effect. And I think it's the same, for me, there are a lot of parallels with the COVID vaccine, is that if the risk from the vaccine were higher than the risk of just living and getting myocarditis from COVID or another virus, then it would be a very different decision.
Okay, well, thank you. So maybe we move on to another topic, and this one is for Dr. Willis. What is the plan for people who have had COVID-19 and therefore have natural immunity?
So natural immunity is real. There's this sort of debate, and I think it's sort of a false debate, whether natural immunity confers protection. I think there's no question that natural immunity does confer protection against COVID-19 and severe outcomes. I myself was infected in March and benefited from an interval of natural immunity before I was able to get vaccinated myself. But I know that having been vaccinated myself, that level of protection was enhanced significantly. I was way more protected and am and remain more protected because I was vaccinated on top of natural immunity acquired through being infected. I also was incredibly sick for 2 weeks and wouldn't wish that on anyone. So the short answer is that natural immunity does offer some level of protection, but it is not a reason not to get vaccinated, and vaccination offers added protection on top of that for people who have been infected in the past, and is not sufficient in itself. Natural immunity does not protect you well enough alone, partly because when you're infected, the dose, the virus that you may have been infected with, the amount might be not very strong. It might not actually yield sort of a reliable and sufficient, robust immune response the way we know the vaccine in a studied way actually leads to a reliable long-term immune response.
Okay.
I also-
Go ahead.
No,
Please.
I just want to say, we keep using this term natural immunity. It's not unnatural to get immunity from a vaccine. It's, it's a conferred immunity. It's not immunity from infection, but I actually would love to stop using the term natural immunity personally.
It's a good PR. They have a good PR department.
Yeah, it's because it's not unnatural. My immunity, which is all vaccine acquired, is no less natural than yours. My antibodies are organic, right? And so I just think it creates a little bit of a dichotomy, not to get too theoretical or philosophical, but sorry.
And I think the other point is that we see reinfection as well. So we see both breakthrough, we've seen breakthrough infections and we've seen reinfection. Natural immunity wanes and acquired immunity wanes, which is why there is a recommendation around booster shots. So it's part of our immune system, and in waning is part of our immune system. And I think that's where we'll be looking at the prevalence of this disease as we move in the months and years ahead to look at future recommendations around vaccination.
So this next question is for Dr. Santor, and it's one that's come from a lot of parents. And it verbatim, will my children be able to attend school if they're not fully vaccinated?
We anticipate that children will be able to attend school if they're not fully vaccinated, if they receive an exemption. We do not have information yet from the state. There will be exemptions offered for families as we move towards the requirement. It's going to be different than our current exemption policies because of the particular way you pass through legislation in order to have our SB 277. So we are going to be recommending everyone go to shotsforschools.org and to get updates there. As soon as we have any updates around policies or procedures related to exemptions, we'll be sharing that publicly as parents are navigating the new laws that come into place regarding regular approval and requirements for students to be vaccinated to attend school.
So this will be guidance that will be coming at a state level down to us.
Yeah, so it won't be
Local
Marin County
communities.
policy, it's
Right.
state policy that we'll be following. And so
Got it.
we're waiting for that to be published on the Shots for School website.
Okay, thank you. Dr. Branco, could you please give some statistics in regards to 12 to 19-year-old boys? What is the rate of myocarditis with COVID versus vaccine-induced myocarditis?
So the rate I mentioned earlier of myocarditis related to the COVID vaccine is about 66 cases per million doses administered. Non-COVID related myocarditis is about 18 cases per million in 15 to 18-year-olds and 8 per million. And when you include younger kids, again, it's most common in those adolescent boys in the 15 to 18-year-old age range. So there's no question that there was more myocarditis than we would have expected just from other viruses or other causes. I think the key point is myocarditis from COVID, which is a real concern. Myocarditis is not the only significant illness that we see with COVID. Children, and especially the 5 to 11-year-old age group, is susceptible to something called multi-system inflammatory condition, or MISC. 9 is the median age for kids to develop MISC from COVID. And so again, those of us who take care of kids are excited to have them protected and protected against that condition, which is an inflammatory condition that can lead to cardiac effects and myocarditis as well. Okay. And, again, back to my previous point, the myocarditis that we're seeing with the COVID vaccine is very different from myocarditis that is vaccine acquired, that's virus acquired or due to an illness.
Thank you. Dr. Willis, you've set a goal that 75% of the 5 to 11-year-olds eligible for this vaccine will have it by the winter break. Can you talk to us about why you set that goal? Why 75%? And what happens if we don't reach it?
Yeah. Well, we've been setting goals all the way along. We think that's one of the ways to organize our radical collaboration, is to have a North Star that we're looking to together in terms of our operations. So when we set a goal like that, it's in collaboration with all of our healthcare partners, our hospital partners, our pediatricians, to say, what do we think we can achieve and how do we get there? We set goals at almost every single important benchmark for us in our vaccine distribution. We had a goal: 50% of our residents age 65 and older received their booster by November 12th. We're at 44%. So we're reaching that goal. We had set a goal that we wanted 80% of our entire population vaccinated by the beginning of this month, and we achieved that goal. So there's an important, I think, organizing fact around having goals like that and standing to them. It so happens in this case, if we get 75% of our 5 to 11-year-olds, that's 15,000 of 20,000 kids in that age group. That will be 85%. That will mean we have vaccinated 85% of our entire population. And that's a number that many people are holding up with the R0, the reproductive number, the level of infectivity of the Delta variant. We might achieve what some refer to as herd immunity with that 85% overall coverage. So if we're successful in reaching 75% of our 5 to 11-year-olds, we will be 85% across the board for everyone. And that's going to be an important benchmark for us in terms of our overall protection as a community.
Dr. Santora, there is a bit of confusion about what's required, what is recommended, what's mandated regarding vaccinations for this age group. Can you talk a little bit more about that? Where are we currently and what could be coming, and any other information related?
So at this time, it's recommended that your 5 to 11-year-olds get vaccinated. It's not required. All vaccines require, regardless of what's required for school attendance, are personal choices, and parents need to read the information, talk to trusted healthcare providers, and make an informed choice that's best for their family. We are preparing for the requirement that 12 and above, adolescents over 12 will be requiring the COVID-19 vaccine to attend school. And again, there'll be information forthcoming around exemptions and what would be the process for exemptions. We have not yet heard about requirements for the 5 to 11-year-olds. And so that, again, is something that we'll be looking to see if that does come from the state and governor's office for a requirement to attend school. We had seen data, though, around the other vaccines that are required, and they were required at significantly lower levels of annual deaths for these vaccines. So when we look at hepatitis A or varicella, the deaths per year prior to vaccination were significantly lower than what we see for children aged 5 to 11 infected with COVID-19. So we need to be prepared that it may become a requirement, not only for the 12 and above, but for also 5 to 11, but for parents to also know that there will be an exemption process for these vaccines. And again, it's just, for us, it's critically important that it's an informed choice, that families have to review the information. Every family receives a vaccine information sheet prior to receiving the vaccine, which will have all the side effects listed, and make the choice that's best for their family.
Just add something to that, because it does seem like there's a sort of fundamental misunderstanding currently around the vaccine. You know, a lot of the pushback that we see now and questions and concerns are, why are you mandating this vaccine? And the fact is, we just want to be crystal clear that this is optional, right? Well, the reason we're hosting forums like this, we're talking about this, we're educating, we have unequivocal support. We believe in the value of this vaccine for the safety and efficacy that it will offer individuals and the community. But it is a choice. So no one is requiring this vaccine currently. There is a possibility in the future that it would be required under the state of California to attend school. That's really has not yet been defined, but we just want to be clear again that we are not requiring this vaccine in Marin County. This is a choice.
Great, thank you. Dr. Branco, can you comment more on vaccines and cardiomyopathy? What is it? Why is it occurring? Is it occurring? And why, if it's occurring, is it predominant in more certain groups or age groups?
Yeah, so, as I said earlier, myocarditis, or the cardiomyopathy. Cardiomyopathy is a little different. Cardiomyopathy is an abnormality of the heart muscle that can mean a lot of different things. What we're seeing with the COVID vaccine, or what has been seen with COVID vaccine, again, 66 cases in a million, is inflammation of the heart muscle. As I said earlier, we see that with other viruses. It's typically a much more severe illness. The children who have had myocarditis from the COVID vaccine, the majority of them were treated with ibuprofen. Early on, there were some that were treated more aggressively with steroids or IVIG and different immune treatments, but the treatment now has really, the standard treatment has become rest and ibuprofen and close monitoring by a cardiologist.
Great, thank you. Dr. Willis, can you discuss the relationship or the value of the long-term health effects from the COVID vaccine, or the potential long-term health effects from the COVID vaccine over the COVID virus itself?
Yeah, I think we've addressed that, and just to repeat we are unfortunately, I think, looking at a reality that COVID-19 SARS-CoV-2, the virus that causes COVID-19, is going to be part of our environment. It's part of the ecosystem forever. And the Delta, there might have been some hope of eradication early on when it was less infectious, but especially after the Delta variant came, and it really showed that it was much more infectious and that there's evolutionary advantage to this virus to become even more infectious. And it's very likely that this is here to stay, and it would just be added to the list of other known parts of our environment. As human beings, our immune systems can develop antibodies, so that it allows us to coexist with this virus the way we coexist with other infectious diseases. What we're talking about is a method to acquire that immunity, those antibodies, in a way that's safe and effective through vaccine. So the long-term benefits of vaccination are really for peaceful coexistence with a new threat. And in the absence of the vaccine, that would be manifest in what you see in India, what you see in Florida, what you see in other parts of the world where vaccine rates are very low. It's really through death and suffering is the way immunity is acquired in those settings, because people are getting infected. We have the benefit of a vaccine that prevents us from that method as a community of acquiring immunity. And that's what we're talking about.
I just want to add that we've had such a privilege in Marin County because of our high vaccination rates that we haven't seen what states like Florida has seen. And I know there's attention on looking at, well, there's lower case rates in Florida now than there is in California, but that has been due through significant suffering and deaths. It's because the amount of people infected surged so high, the hospitals were so stressed, people died. There was significant lives lost for it to return to a lower case rate. And we've just been so fortunate in California and specifically in the Bay Area that we haven't had to see these deaths. It's hard to see during the past 3 months, a younger group of people who have been hospitalized that were all preventable. And I think that's something that sadly people have become accustomed to that reality in other states. And again, we just have a privilege to have avoided it, but I don't think suffering and the death is the way to, peacefully coexist. But I see that in the news, in some of the news clips is again, oh, Florida has won. It didn't win. It won on many, many lives lost and parents lost. I think that's the other data point that we've been starting to see where we often focus on children having mild disease, but we also have to look to the parents. I think there's more than 140,000 children who have lost a caregiver in their lives because of this disease. And we've seen that most notably so in those states and areas that have the lower vaccination rates.
And, and with that, over even in the 5 to 11-year-old age group, 140 is the current number of children who have died. And so, think of the tragedy for those families who have lost a child to COVID, to what is now, as of today, a preventable disease for those children. You mentioned in our introductions, both Dr. Willis and I worked on the Navajo reservation, right. And the Navajo, for many reasons, were heavily impacted by COVID. And, my colleagues who are there, people I know who work there, tell me that every family has been affected by COVID. Every family has lost someone, has had someone in the ICU, has been, separated, quarantined. And we are privileged here. We're very, very lucky. And even though there are disparities, even in how COVID has affected our community, I think, you have tried to address that, and we are in a very good position. If I can backtrack a little bit to your answer around mutations and evolution, we all get these questions from our kids about, I'll never use algebra again. Why am I studying algebra? And one of my sons who's in high school asked me a few weeks ago, learning about this evolution, like, when am I ever going to use that? And I got to say, like, you're watching it happen right now, because this viruses are meant to reproduce. Viruses are trying to create new viruses and infect more people. And one of the ways they do that is by being really sloppy and by changing in a way that becomes more infectious. We saw that Delta changed in a way that was more infectious, and in kids, at the height of the Delta surge, 25% of the new cases were in children. And we have been very fortunate that COVID has not affected children as much as it has adults. We've been very fortunate that our kids have been able to be back in school. That wouldn't happen with flu. We all know that if this was influenza, we never would have been able to reopen schools because influenza likes kids. It's transmitted really efficiently by kids. If COVID is only happening in kids because they're the only ones that are not vaccinated, COVID will eventually find a way. And it will eventually mutate to a form that is more infectious in kids. I am convinced of that. That's just the way viruses evolve. That's the way viruses change. And so that's another reason why I think it's really important for us to vaccinate kids, is to not have them continue to be susceptible to this virus that may become more and more transmissible.
Interesting. Well, the next question has to do with the men and women that serve in our schools to educate those kids. And will all school staff be required, Dr. Santora, to be vaccinated going forward? And what if someone refuses?
So we have heard from the governor as well that school staff are going to be required to receive vaccinations. First of all, I'm just really proud of Marin County. We have 95% of our school staff have been vaccinated. And I just looked at data where, as last year we saw staff to student transmission, this year we're not seeing staff to student transmission because of the protections offered, or staff to staff transmission, because 95% of our staff is vaccinated. So we're seeing again the success of our vaccination, and school staff probably are one of the most vaccinated sectors. So we are preparing again for this the state order that school staff will require vaccinations. And then there are already religious and medical exemptions that are allowable for school staff. And then there also may be schools that opt to be 100% vaccinated and to require vaccination and not allow for exemptions. And that would be something that we'll be looking to and providing guidance for. But again, we're just really fortunate in Marin County that 95% of school staff are already vaccinated. So thank you for getting vaccinated.
Thank you for having the opportunity for us to get vaccinated. Dr. Branco, for children with severe allergies to things like peanuts or other things, is it recommended to get the vaccine at their doctor's office versus a superpod clinic? And will there be trained and prepared staff to deal with situations at the large clinics?
Having worked in the superpod clinics early on, vaccinating adults, I can attest that they are ready to deal with allergies. They've got well-trained staff and equipment. I think children with allergies will be monitored, right? The recommendation is that there's a longer monitoring period for children with allergies. You should bring your EpiPen with you. But I think parents should feel very comfortable having their children vaccinated in that setting. The county has done a great job of preparing for any emergency that might come up. That being said, the answer is always, if you have questions, call your pediatrician. And if you have a specific case, we are ready and willing and anxious to answer all of your questions.
And again, just a reminder, in the clinical trial, more than 3,500 kids who received the vaccine, there were no cases of anaphylaxis. So again, that's very, very reassuring. And it's not something we've even commonly seen at all in all age groups that have been vaccinated in Marin County.
I can add another about sort of preparing our vaccine sites. Not only are we ready for any allergic reactions that might occur, but there's other differences with the vaccine sites that we're setting up for our kids. We've had a child experience specialist, I think is the name of it. Child life specialist. Yeah. Help us, guide us into what an environment would look like for a child to feel less afraid if they're worried about getting about needles, getting a vaccine. And so our large scale vaccine sites are going to be, for our kids, are going to be colorful, friendly, welcoming. There'll be music, fewer visits per hour. So it's a little bit of a longer period for the hand holding that needs to occur. And the staff will be prepared to sort of make that a more friendly experience for our kids who might be afraid.
That's great. This has sort of been touched on, but the sheer number of questions like this, I think it warrants asking this question. I understand that 5 to 11-year-olds will have a lesser dose. What if your child is turning 12 2 months after the initial vaccination next month? Should we wait?
No.
Right away.
You get the dose that your child is at when the vaccine becomes available. And we've heard that a lot. We just that kind of that 11 to 12-year-old, absolutely, we feel confident in the immune response that we've seen at this dose. And we looked at all different age groups, and we saw that the 9 to 11-year-olds have a very strong response receiving the 10 microgram dose. And again, we'll have a lower side effect profile as well. So I would strongly recommend getting the dose at the age you're at. If you start, there's also that question like, oh, what if my kid changes age? So if they start at the 10 microgram dose, they'll follow up with the 10 microgram dose. And that's completely appropriate, safe, and effective.
Okay, and
Get the
Dr.
vaccine right away. Get the vaccine as soon as you're eligible. The last thing you want is to regret that you didn't get the vaccine soon enough, even if it's only a couple of weeks.
And the other thing that we commonly see, and I talk about this a lot, is we are expecting to see an uptick in cases among kids in those first couple of weeks right after vaccination, because that's when people lower their guard. You're not fully immunized until 2 weeks after your second vaccine, but we see people's risk behaviors increase right after the first dose. So it's not uncommon for us to see a new case of COVID-19 in those first 2 weeks. So just really remember, it's going to take the full 5 to 6 weeks for your child to have received the immunity offered by the vaccine, and to still manage your risk in these next 6 weeks.
That's right. And those that get vaccinated in the next couple of weeks, that's going to land right around the winter holidays. If you want full immunity for the winter holidays, you got about a 2-week window to get that first dose.
Dr. Santora, can the COVID vaccine and the flu vaccine be given at the same time, or is there an amount of time people should wait in between the shots?
Yes, they can be given at the same time. We're recommending them at the same time. We're really concerned this year that we're going to see under vaccination for the flu. That's setting us up for a much more severe flu season. And so I have a convenient-based parenting style. So I see both child getting a vaccine, one flu in one arm and the COVID vaccine in the other arm. We've already heard that kids who have received both shots are doing very well, and they report that the COVID vaccine arm hurts less than the flu vaccine arm. So,
and to the pharmacist who told my patient this week that they had to wait 2 weeks, that's old information. When COVID vaccine was first given, there was a 2-week window pre and post the vaccine, really to make sure that we knew what to expect for side effects from COVID vaccine. That has gone away. We can now give any vaccine at the same time or within 2 weeks. And so we in our office routinely give flu and COVID either same day or separated by not too long.
Okay, so we're getting close to our hour. Just to be mindful of the time, we have time for a couple more questions, and then we do want to share some information about next steps for our community. Dr. Branco, can you specify what the characteristics are of the children who get hospitalized for COVID? What underlying conditions do they have?
Yeah, so a third of the kids who are hospitalized for COVID end up in the intensive care unit. There have been over 23,000 admissions. 30% of the children who've been hospitalized for COVID have no underlying condition. They're healthy children who develop COVID and are hospitalized. And so most of the children who are ill with COVID and are hospitalized do have cardiac conditions, underlying cardiac conditions, neurologic conditions, cerebral palsy, or seizure disorders, or pulmonary conditions. But there is still a significant number, 30%, who have no underlying condition and are healthy kids. And so that is why we're anxious to get all kids protected. MIS-C, which I mentioned, is this inflammatory condition that can happen with COVID. And again, the peak of that is at age 9. And so we want to make sure that those 5 to 11-year-olds are protected so that we aren't seeing the inflammatory condition. I'll also tell you that of the kids in my practice with cardiac conditions, with lung conditions, with neurologic issues, when I talk to their specialists, when I talk to Dr. Rule, my infectious disease friend and consultant, they all recommend those kids get vaccinated because the risk from the vaccine is far less. The group of pediatricians is putting together a letter encouraging parents to vaccinate their kids, and I can tell you the longest emails I'm getting are from the specialists, the cardiologists, and the neurologists who are, really behind this idea that we need to protect kids by getting them vaccinated.
I think also just to point out that we have another privilege in Marin County that's not being seen in the South is that children who have high levels of obesity and diabetes are at highest risk for hospitalization. And also there's tremendous racial disparities in our country for hospitalization. And again, our high vaccination rates have protected our adolescents and kids from experiences that are being deeply felt in the South and other states of children and adolescents requiring hospitalizations, which is another privilege that we have in Marin County.
Okay, so I think it's time now to bring up some slides where we can talk about the next steps for our community. And while that's coming up, let me just thank you for addressing so many of these important questions, both in the presentation materials and in the roundtable that we just had. We covered a lot of ground, and I know a lot of people had great information coming their way. So here we go with our super pods.
Right, so we have, starting this Saturday, we have the first of our weekend super pods that will be going through the months of November and December. First dose is generally through November, and the second dose is generally through December. On each of those days, Saturday and Sunday, it'll be at least 1,000 doses available to our residents. Tomorrow, maybe even tonight, there may be appointments available. We are in the process of actually making appointments available to be scheduled into. You can check tonight to start booking appointments for Saturday, November 6th. That's at Miller Creek, also November 7th. And then the second doses for that particular super pod will be the 4th and 5th of December. And we'll have similar pairings of first and second doses through these super pods available on our website through weekends in November. We're also at the same time having clinics at specific schools dedicated to the students within those schools, especially our larger public schools and low-income communities. In addition, our pediatric practices will be starting to offer vaccine as soon as they're able to get the vaccine. The first doses arrived to public health departments and some of our larger providers like Kaiser. Kaiser will start offering vaccines, we hear, on Monday, with appointments starting to be available at Kaiser tomorrow. And then obviously pharmacies as well. We'll have 20 pharmacies across Marin County that will be offering vaccines. Many of us are used to going to pharmacies for our flu shots or even COVID boosters. They will also be offering vaccines for our children. The best way to go to see all of those options at once is to go to getvaccinatedmarin.org. That's getvaccinatedmarin.org. And we'll have that list of all the different options across the county for people to go ahead and sign up for appointments.
Well, great. Well, thank you for a very informative hour and for all of your work in our community that has really guided us in so many important ways. We thank you very much. And I know our parent community is grateful for your participation. And thank you all for joining us. And we wish you a very good evening. Thank you. Bye-bye.
Thank you.
Thank you.